Hi, this is Brandy from Mana Health Partners, bringing you our annual education video, and this is on evidence-based practice at the point of care. And this is specifically for nurse practitioners in Pennsylvania and how to prescribe safely. Many of our nurse practitioners are either new to the field or haven't had extensive experience in skilled nursing facilities. Others have been practicing for some time, but not specifically in this setting. This training is designed for all of you because safe prescribing in skilled nursing facilities requires specific understanding of state regulations, collaborative practice agreements, and unique needs of all of our patients. We'll be focusing on safe, compliant, and coordinated prescribing practices that align with your collaborative agreements and our facility protocols. Before we dive in, let's take a look at what we're going to cover in this training. We'll start by reviewing the scope of practice and the role of the nurse practitioner in the long-term care environment. From there, we'll look at prescriptive authority and the legal guardrails that define how and what we can prescribe in this setting. We'll explore how to integrate evidence-based clinical tools and apps into everyday decision-making. Because safe prescribing isn't just about guessing, it's about using reliable, accessible resources at the point of care. We'll also cover lab ordering and medication monitoring protocols, when to order, how often, and why it matters for patient safety and regulatory compliance. Then we'll bring it all together by discussing antibiotic stewardship and how to use the McGear's criteria in unison with Interact Care Pathways to guide appropriate evidence-based treatment decisions. We'll go over before you prescribe algorithm to create a consistent clinical thought process and highlight some of the most common pitfalls we see in this environment. Finally, we'll wrap up with documentation and regulatory considerations, and I'll share some additional resources you can use after this training. At the end, there'll be a page with all of my contact information. It has my email address, my phone number. You can call, you can email me with any questions. You can always do the WhatsApp chat and get feedback from other nurse practitioners as well. When we talk about the role of the nurse practitioner in this setting, we're really talking about the heart of what we do every day. As nurse practitioners in skilled nursing and long-term care, we are responsible for managing selected medical problems that fall within our training, licensure, and scope of practice, always in alignment with our collaborative agreements and facility protocols. That means we can order diagnostic tests, initiate appropriate therapies, and order skilled physical and occupational therapy when clinically indicated to support patient recovery and function. We also play a key role at initiating, monitoring, and adjusting therapy for uncomplicated acute conditions, such as mild infections, respiratory issues, or pain management, when appropriate and consistent with the care plan. A major role is managing patients with stable chronic conditions, including hypertension, diabetes, COPD, depression, and other behavioral health conditions with an established diagnosis and treatment plan. By practicing within this scope, we can intervene early, help maintain stability, and often prevent unnecessary hospitalizations. Everything we do is grounded in evidence-based practice and state-specific nurse practitioner practice authority, supported by our collaborating physicians. This slide is the cornerstone of what we do as nurse practitioners. It outlines the legal guardrails for prescribing across acute, chronic, and preventative care. In Pennsylvania, nurse practitioners can prescribe, dispense, administer, or order any drug within the limits of their scope and licensure, and when applicable, under a collaborative agreement. Here's how that translates into practice. For acute care, when a patient presents with a new or worsening issue, we can prescribe short-term treatments like antibiotics, steroids, or other appropriate therapies, as long as we document clinical justification and stay within regulatory boundaries. For chronic care, conditions like diabetes, hypertension, COPD, congestive heart failure, seizure disorders, and pain management, we have the authority to initiate, titrate, and maintain ongoing medication regimens. This requires monitoring labs, following evidence-based guidelines, and staying aligned with DEA requirements when controlled substances are involved. And preventative care. We can order vaccines, vitamins, supplements, and screening labs like lipid panels, A1C, thyroid labs, as part of maintaining or improving baseline health. The big reminder here, prescribing isn't just clinical, it's legal and regulatory, especially with controlled substances, your DEA license, state regulations, and documentation, which are non-negotiable. This is why understanding your scope of practice and prescriptive authority is critical before you ever hit e-prescribe. On these slides, some of them look very busy, but I try to either put a URL number or the references where I obtained this information so you understand that these are not just thoughts or ideas, but actually protocols and evidence-based practices that are from multiple different resources as well as your state regulations. When we talk about managing selected medical problems, we're talking about what lies at the core of the nurse practitioner practice in Pennsylvania. Under state law, nurse practitioners have the authority to diagnose, to treat, and manage common acute and chronic medical conditions that fall within their training scope and certification. This includes the ability to order diagnostic tests, initiate and adjust treatments, and monitor a patient's response to therapy. We discussed that briefly in the last slide. We can initiate, monitor, and alter therapies for certain uncomplicated acute illnesses, as well as chronic stable conditions. The key idea here is to know your scope, practice within it, and use evidence-based tools to guide your clinical decisions. This is where being proactive makes a difference in both patient outcomes and regulatory compliance. When we talk about prescriptive authority, it's important to remember that not every nurse practitioner practices at the exact same level of independence. Some are very experienced and some are newer, and that's okay. Pennsylvania's collaborative agreement and the legal guardrails are there to support safe and consistent prescribing, no matter where you are in your practice journey. Under Pennsylvania law, nurse practitioners may prescribe both controlled and non-controlled substances within the scope of their collaborative agreement. This includes scheduled 2 through 5 medications with a maximum 30-day supply for scheduled 2 controlled substances. That's slightly different than here in the state of Florida, where you're only allowed 7 days. Unlike some other states, there's no distinction between psychiatric and non-psychiatric prescribers when it comes to this rule. It's 30 days for all Schedule IIs. Every nurse practitioner must check the PDMP before prescribing controlled substances. This is required by Act 191, and it's critical in every step that we do. Now in Florida, we have something called E-Force. In Pennsylvania, it's called PA, PDMP. So that's where you would be checking. The bottom line is prescribing isn't just about signing your name on the bottom of an order. It's ensuring that the treatment is clinically appropriate, legally compliant, and defensible through solid documentation. This slide is really important because it highlights exactly what we as nurse practitioners are legally authorized to do when it comes to medications. Under Pennsylvania law, nurse practitioners can prescribe, dispense, administer, or order medications, including controlled substances, as long as it's within our scope of practice, collaborative agreement, and licensure. In our setting, we don't typically administer or dispense. Nursing and pharmacy handle that, but our name is attached to that prescription. And that means ultimately we're responsible for ensuring it's clinically appropriate and legally compliant. When prescribing Schedule 2 through 5 controlled substances, you need a valid DEA. And it's not just about holding the DEA number. It's about understanding and following federal and state prescribing regulations. That includes documenting the correct indication and justification, prescribing appropriate quantity and duration, completing mandatory PDMP checks prior to prescribing, and ensuring proper follow-up and monitoring. And even though we may not physically hand the medication to the patient, as the initiating prescriber, we carry the legal and regulatory responsibility. One thing I want to add is the PDMP checks prior to prescribing. Unlike the states of Florida and Texas, in Pennsylvania, you have to prove that you did that. So when you do the PDMP check, you're going to put it into a PDF and you're going to drop it under the miscellaneous category as PDMP verification every single time. Because in Pennsylvania, you're required to show that you did indeed check. I know this slide looks a little bit busy, but that's because pain medication carries a lot of responsibility for the prescriber. If we make the decision to start a patient on pain medication, especially a controlled substance, we must be fully prepared to support that decision in the medical record. That means 3 key elements need to be addressed. Clear medical indication. The rationale for prescribing must be explicitly documented. This protects the patient and the prescriber. Thorough documentation. Include the history, the assessment, and a clear rationale for starting or continuing the medication. And a structured monitoring plan. Explain how we'll assess the patient's response, monitor for side effects, and evaluate the signs of misuse or diversion. We also need to think ahead. What's the exit strategy? Are they going to be on this medication forever, or is this a temporary medication? How often are we reassessing pain and function? Are there other non-pharmacological or lower risk alternatives that could be used? Pain management is appropriate and often necessary, but it must be done intentionally, defensibly, and in alignment with state and federal regulations, including PDMP checks and DEA prescribing guidelines. Now you'll see over here that there's 10 different areas that you should be documenting when you document on pain management. So not only the location of the pain, but the frequency and duration, the intensity and severity, the quality and character, the onset and course, any aggravating factors, relieving factors, any associated symptoms, impact of function, and the interventions and response. All of that is necessary when initiating and implementing new pain medication. When it comes to controlled substances and pain management, the best thing we can do for both the patient safety and provider protection is to make sure that there's one consistent prescriber managing that plan of care. Pain management should follow the patient, meaning the designated pain management provider is responsible for evaluation, dose adjustments, and refills. As nurse practitioners in skilled nursing and long-term care, our role is to support the plan, not to create multiple layers of prescribing. That means no refills unless absolutely necessary. Let pain management do that. No dose adjustments unless you are the designated pain prescriber and that is clearly indicated. Avoid multiple providers prescribing for the patient because that's where things go wrong. Having too many hands in the pot doesn't just create confusion, it increases the risk for medication errors, diversions, and regulatory red flags. Keeping pain management with one provider keeps the plan consistent, traceable, and safe. This slide is one of the more important ones in this section because when we prescribe a Schedule II medication, there are very specific legal and documentation requirements that must be followed. So in the state of Pennsylvania, Controlled II substance, the prescription must be written with clear documentation of indication, dose, quantity, and duration. There are no refills permitted for Scheduled II drugs. If more medication is needed, an entirely new prescription must be written with updated clinical justification. We're not now just writing the prescription, but we're updating the clinical justification. The Pennsylvania PDMP checks must be completed prior to each prescription or renewal. If the prescription is for acute pain, duration and rationale must be clearly documented. If the prescription is for chronic pain, the treatment plan, reassessment schedule, and risk-benefit discussion should be reflected in the chart. A key point in long-term care and skilled nursing facilities. Only prescribers with active DEA registration and authority for Scheduled II substances can prescribe these medications. For psychiatric indications, prescribing must fall within the nurse practitioner's specialty and scope of practice. These requirements are not just regulatory red tape, they're in place to protect patients, reduce diversion risk, and ensure legal compliance at both the state and federal level. This is a really important slide because it gets to the heart of how we make clinical decisions. How do we know which medication is the right one for a patient? It's not about what we used to do 5 or 10 years ago. Medicine is constantly evolving, and so should our practice. We don't rely on what worked for the last patient. We rely on evidence-based practice. What's most appropriate now, backed by the most current research and clinical guidelines. That's where these clinical tools and apps come in. If you're not using at least a few of these resources, you're making prescribing harder than it needs to be. These tools simplify your workflow, make you more accurate, and more importantly, they help you prescribe more safely. They can give you dosing recommendations, interactions, contraindications, renal and hepatic adjustments, and guideline-based treatment plans right at your fingertips. This is how we stay current and protect our licensing while giving patients the best care possible. So here's one on Lexicomp, which is the gold standard for real-time drug information. This is one I don't specifically use, not because I'm not familiar with it. It's just one that is integrated into the hospitals, and I use other resources, and we'll go through those. But this is great for adult, pediatric, renal, and hepatic dosing, drug-to-drug interactions, very important, lab monitoring, adverse effects, therapeutic ranges, even including off-label dosing with supporting evidence levels. And the URL is listed on the bottom. MicroMedX is also a comprehensive and evidence-graded app that you can use. It has precise dosing by indication and route, black box warnings and contraindications, evidence grading for off-label uses, and IV compatibility, pediatrics, and geriatrics, which is perfect for our population. Why it's trusted? Most major hospitals integrate well with this system. And the URL is listed below if you're interested in this. Up to date. So many of you love up to date. It's not my favorite. I used it when I was in nurse practitioner school. Lots of evidence-based research associated with it. There's clinical guidelines. There's literature attached to it. It is an amazing program. It's peer-reviewed. It's frequently updated, and it's widely cited in nurse practitioner practice and academia. That's why I used it while I was in school. But I really want the answers to how to prescribe versus a collaboration of what peer review says is the problem and the solution. Hippocrates. Now this is my gig. So Hippocrates is, I've got it on my phone, a rapid verification of drug dosing interactions, pill ID, basic guideline summaries, useful for outpatient and telehealth encounters. I have it on my phone and I just look it up when I'm doing patient rounds. It's easy to use at point of care, meaning you can just look it up right in front of the patient. It's free. I do have the premium one, which does give me a little bit more. It gives me some diagnoses and then pathways to get through that. So if you don't have Hippocrates, download at least the free version of it. It's not going to give you the answer. If you already know the answer, vancomycin, if you already know the answer, amoxicillin, it will take it from there. So you do have to know the medications prior to looking it up. This is my all-time favorite. And so if you go on the app store, you can look at this. This is the app picture. It's $9.99 a year. It is the most amazing app. So it's one of my favorite tools for quick empiric antibiotic dosing decision making. So it was originally designed for emergency medicine, which makes it fast, clear, and clinically practical. For nurse practitioners in long-term care or primary care, that's a huge plus because we're often making antibiotic decisions at the point of care, not after an hour of research. So you can find first-line and alternative antibiotics based on suspected source of infection. So when you come down here, you find the area that you're looking for, and when you click on that, it will give you multiple different infections. You click on the infection, and not only do you have the primary antibiotic, but several others in case there's allergies. You can check common pathogens and typical coverage, which is incredibly helpful for UTIs, pneumonia, skin, and soft tissue infections. You can see standard dosing as well as, if scrolling to the bottom, renal adjustments right in the app. And it gives you a sense of what evidence-based and guideline alignment is instead of relying on old habits such as just give them a Z-Pack. And one thing I want to emphasize, if you don't know the dosing of a medication or the frequency, let's give an example. You've got a patient with pneumonia and you're going to give them amoxicillin. And you just remember that amoxicillin comes in 500 milligrams, and so you're going to order 500 milligrams twice a day. That is not evidence-based practice, documentation, and prescribing. This app will put you right into the pneumonia, and it will say amoxicillin 500 milligrams every 8 hours for 7 days. So it gives you the entire pathway and not just the medication. Then if you wanted to verify through Hippocrates, you could see if it's a community-based infection or in-house. So I love the ability to use this. I recently saw an antibiotic that was prescribed. It was zithromycin, 500 milligrams by mouth every day for 7 days. Now, that's not even a protocol. It's not evidence-based practice. You'll never find that anywhere. They may have had it or used it somewhere else, but the doctor came back the very next day and discontinued it and put him on 500 milligrams for the first day and 250 milligrams for day 2 through 5. That makes a difference. When we do evidence-based practice, the doctors can't come in and discontinue our orders because we're doing it the right way and we're no longer guessing or trying to come up with things at the tip of our fingers. We know it already because we've got it somewhere, whether it's on your desktop, whether it's on your phone. I love those phone apps that you can use. This one is one of my favorites. These apps are not made to replace clinical judgment, but it does support rapid, appropriate, defensible prescribing. One tip is you pair the EMRA antibiotics, with McGear's criteria and interact pathways before starting any antibiotic, and it commonly reduces inappropriate prescribing drastically. Amazing. This slide is a great reminder of the procedural side of our role as nurse practitioners. If we're doing a procedure, they're all attached to CPT codes. So those are all billable on top of our evaluation and management. So obviously in skilled nursing, we're not going to be doing some procedures such as like a pap smear. However, many nurse practitioners are trained and within their scope to do a variety of other procedures. This includes joint injections, peg tube changes, suprapubic cath replacements. If it's something you're trained to do and it falls within your scope, you are absolutely able to perform it. That being said, scope isn't just about what's legally allowed. It's also about competence. If you've never given a joint injection before, it would be inappropriate to just pick up a needle and try. In that case, it would be expected that you receive additional training, supervision, and guidance before independently performing the procedure. So take me for example. I've watched several joint injections of the shoulder. I have never done one. I don't know the landmarks specifically. Just watching someone do them does not make me clinically competent. So let's say I am clinically competent and I've done multiple shoulder injections with a physician watching me, whether it's in clinicals or out in the field, and now I need to give a knee injection. Does that make me clinically competent at giving that? No. Different landmarks, different type, different everything. So yes, you might be using the same medication. Yes, the point may be the same. The diagnosis is close to the same, but are we competent to do that? I don't have that clinical skill set. I have never done that, so I would not be able to do that. The takeaway of this whole thing is that if it's within your scope and you are trained, you can do it. If you are not trained, don't do it without proper guidance. This protects you, your license, and your patient. If I was still rounding as primary care, I would ask one of the physicians or nurse practitioners who is very skilled at that. I'd get a landmark book and make sure I understood how to do it. And when those came available, I would ask if I could do that and I could learn. After you've passed off multiple times and you're clearly competent to do that, then you would be able to do that independently. This is a simple but important reminder. Sometimes in the hurry of rounding or during an initial assessment, providers order labs without doing a thorough review of the patient's diagnoses, current medications, or past lab results. But here's the reality. In order to recognize meaningful changes in a patient's condition, you need a baseline to compare to. Baseline labs aren't just a box to check. They're how we identify early shifts, catch complications sooner, and make safe prescribing decisions. If we start a patient on medication that impacts the liver, the kidneys, or electrolytes, we need to know where they're starting from. If they have a chronic condition, baseline values help us determine whether what we're seeing is new or part of their chronic picture. This is particularly important in long-term care and primary care, where we often inherit patients with fragmented medical records. Taking the time to establish or review baseline labs up front saves you time, protects the patient, and keeps your documentation defensible. This slide is here to remind you that our decisions and lab monitoring aren't based on personal preference. They're grounded in national standards and regulatory expectations. As I said, in every one of these slides, you've got evidence-based protocols, whether you've got your resources at the bottom, whether you've got your URLs to refer to, whether you've got your laws and legal Board of Nursing regulations, you've got references and resources where I got this information from. So as far as multiple organizations, why are we using them? Why are we using their standards? Because it's evidence-based practice. So for example, the U.S. Preventative Service Task Force, we would be utilizing their advice as to when we're going to do certain things, including your vaccinations, including immunizations and labs. So like the CDC, we would use for infectious disease, vaccinations, lab-based protocols, the FDA for medication labeling, monitoring recommendations, lab-based protocols, the National Institute of Health for clinical practice guidelines and evidence-based treatment standards, CMS, which in our environment sets regulatory expectations for long-term care and skilled nursing. CMS is who comes in and does our evaluations in the facility. And Joint Commission, IDSA, and other specialty organizations for disease-specific best practice. When your documentation shows that your decisions align with these standards, it does more than just justify your care. It protects you legally, it strengthens your clinical judgment, and it keeps the facility survey ready. So when you're ordering a lab, you're not just following personal practice, you're aligning with national evidence-based guidelines and regulatory expectations. The CBC and CMP are some of the most foundational labs we use in clinical practice. They give us a broad snapshot of the patient's overall health. CBC for infection, anemia, or hematologic issues, and a CMP for liver, kidney, and electrolyte status, as well as protein and albumin. For new admissions or medication starts, this is your baseline anchor. It allows us to detect changes early, adjust medications appropriately, and catch complications before they turn into crises. These are also some of the most defensible labs in order for long-term care and primary care because they're evidence-based, guideline-supported, and clinically useful in almost every patient population. TSH and A1C are two key labs that guide how we manage some of the most chronic common conditions we see, thyroid disease and diabetes. For TSH, this isn't just about checking a box. Subtle changes can explain symptoms like fatigue, weight changes, cognitive decline, or mood status, especially in older adults. It's also essential before starting or adjusting thyroid medication. For A1C, it gives us a 3-month average of blood glucose control. In long-term care, A1C targets may be different than in younger adults. We often focus on avoiding hypoglycemia and maintaining functional status rather than achieving tight control. An 85-year-old patient with multiple comorbidities may have an A1C goal of 8%. That would be appropriate as we don't want to cause hypoglycemia. Whereas a patient that's 55 that has very few comorbidities, is on very few medications, may have a tighter A1C goal. It may be 6.5. It depends. So every A1C goal is going to be different based on the patient, their age, and their comorbidities. These labs are key for medical decisions, medication decisions, starting, adjusting, or deprescribing treatments. And more importantly, they establish a baseline to track trends over time. Vitamin B12 and vitamin D3 are two labs that can make a big difference in patient outcomes, especially in older adults. Vitamin B12 deficiency can mimic or worsen cognitive decline, mood changes, weakness, and even neuropathy. In long-term care where these symptoms are common, having a B12 level can help differentiate between something we can fix and something we can only manage. Vitamin D3 plays a huge role in bone health, fall prevention, and immune function. And importantly, vitamin D3 is preferred over vitamin D2 because it's longer acting and more effective in maintaining therapeutic levels over time. These labs are simple to obtain, but can have a big impact on quality of life, on mental status, and on fall prevention strategies, especially in frail or high-risk populations. When we start or continue a statin, it's not just about putting someone on a cholesterol medication and then walking away. It's about understanding the why and the what to monitor. A lipid panel at baseline gives us a clear picture of where the patient is starting. It helps determine if a statin is indicated, if the current therapy is working, or if it needs to be adjusted. A SED rate and CRP can be very helpful adjunct labs, particularly in older adults or patients with multiple comorbidities. If someone develops myalgias, fatigue, or other vague symptoms after starting a statin, these inflammatory markers can help you differentiate between medication side effects, other inflammatory processes, or unrelated illness. The goal is not to overorder labs. It is to order strategically with a clear clinical purpose. That's what keeps your practice evidence-based and survey-proof. In long-term care, we see a lot of lower extremity edema, and the default assumption is often congestive heart failure. But not every swollen ankle equals heart failure. A BNP or pro-BNP can help you differentiate between edema from venous stasis or medication side effects, simple volume overload from sodium or fluid retention, and true decompensated congestive heart failure that requires aggressive management. If the BNP or pro-BNP is elevated, it does support a CHF diagnosis, but always interpret it in the context, renal function, age, comorbidities. If it's not elevated, that's a strong signal to look for another cause rather than reflexively just start diuretics. This lab doesn't replace a good physical exam and assessment, but it supports better decision making, reduces inappropriate diuretic use, and helps clarify documentation and coding. Tegretol is one of those medications where lab monitoring is not optional. It is essential for patient safety. Tegretol can affect multiple organ systems. bone marrow suppression leading to leukopenia, agranulocytosis, and even aplastic anemia. Hepatic metabolism, meaning regular liver function monitoring is required. Electrolyte balance, especially sodium, as hyponatremia is a common complication. And of course, serum drug levels to ensure therapeutic dosing and avoid toxicity. This is why you'll often see a front-loaded monitoring schedule, frequent CBCs, liver function tests and levels early on, and then spacing out once stability is achieved. In long-term care and primary care, this is particularly important because patients may have comorbidities and polypharmacy that increase the risk of medications and interactions with other meds and side effects. This is not a set it and forget it medication. If you prescribe Tegretol, you must commit to structured monitoring. If neurology prescribes Tegretol, you must commit to structured monitoring. If psychiatry prescribes Tegretol, you must commit to structured monitoring. This is a medical thing. Your neurologist and psychiatrist are not going to be monitoring these labs. This will be you ordering and following those labs. Lamotrigine doesn't require the same level of ongoing lab monitoring as some of the other seizure medications, such as Tegretol or Depakote. However, that doesn't mean it's hands off. There are still times when lab monitoring is appropriate and clinically important, such as your baseline labs, CBC, CMP, and hepatic function are good in practice, especially with medically complex or older patients. Monitoring may be warranted if the patient develops new symptoms like a rash, fever, or systemic complaints that could signal hypersensitivity reaction. If Lamictal is being used in combination with other anti-epileptics, drug interactions can alter metabolism, and serum levels may be useful in some cases. Lamictal's biggest risk isn't lab-based. It's Stevens-Johnson syndrome with rapid titration or in insensitive patients. So while labs aren't frequent, clinical vigilance is. That's why lamotrigine is in FDA packs, 25 milligrams for 1 week, 50 milligrams for a week, then maybe 100 milligrams from there on out. There are multiple different FDA packs. But if your patient is on or is being started on lamotrigine, I would indeed write an order for the nurses to monitor for Stevens-Johnson syndrome, and I would list some key symptoms of what that would look like, and I would have the nurses monitor that every shift for at least the first couple of weeks of initiation of the lamotrigine. Keppra is one of the more straightforward seizure medications when it comes to lab monitoring. It's generally well tolerated, doesn't require routine serum levels, and in most cases has fewer drug-to-drug interactions. However, that does not mean we can ignore it. A baseline CMP is important since Keppra is primarily renally cleared, and dose adjustments may be necessary in patients with impaired kidney function. Periodic labs may be appropriate in patients with fluctuating renal status. Clinically, it's crucial to monitor for neuropsychiatric side effects, such as mood changes, agitation, or irritability, which are common but often missed. Serum levels can be ordered if there are concerns about non-adherence, toxicity, or therapeutic failure. So while it's not lab heavy, Keppra still requires thoughtful oversight, especially in older adults. Keppra is generally one of the easier seizure medications to manage when it comes to labs, but clinically there are a few things that need to be on your radar. One of the biggest issues I see in my practice is behavioral and neuropsychiatric changes, particularly in patients with pre-existing schizophrenia or other psychotic disorders. Keppra can worsen agitation, irritability, confusion, and even trigger delirium-like presentations. So when you're increasing Keppra or starting it, make sure you're on the alert for that. This can easily be misinterpreted as a primary psychiatric exacerbation, but sometimes it's actually the medication driving those symptoms. So if you're starting Keppra or increasing the dose in a patient with schizophrenia, dementia, or baseline cognitive impairment, it's critical to know their behavioral baseline and monitor closely for early changes. And again, while we don't need frequent serum levels for most patients, baseline and periodic renal function monitoring is key. Depakote is a medication that absolutely requires structured monitoring. Of course, we're going to draw the standard labs, a CBC, and the liver function test because of its effect on bone marrow and liver metabolism. But one lab that gets missed and gets missed often is the ammonia level. Depakote can increase serum ammonia levels even in patients with normal liver function. Elevated ammonia can lead to valproic-induced hyperammonia encephalopathy, which may present as confusion, delirium, lethargy, or even psychosis in older adults. So when starting or adjusting Depakote, it's best practice to get a baseline CBC, LFTs, and an ammonia level. Repeat an Depakote and ammonia level at 8 days post-initiation, and every time the dose is increased, and then every 3 months. You can do it sooner if you're having mental status changes and you think it may be related to an elevated ammonia level. This is critical in geriatric populations where the presentation of toxicity can be subtle and easy to misattribute to dementia or psychiatric illness. This is one of the most important and often overlooked parts of what we do as nurse practitioners. Care coordination isn't just making a referral and walking away. It means actively managing the handoff to make sure the patient actually receives the care they need. For example, when referring a patient to cardiology or neurology, it's not enough just to write refer to specialist. We should clearly document the reason for the referral, the urgency, any relevant labs or imaging, and what question we're asking the specialist to answer. Transition management means making sure that once the patient leaves our facility, whether that's to the hospital, another facility, or outpatient follow-up, that there's a clear, structured communication about medications, diagnoses, and follow-up needs. This is also where solid documentation protects you. Why the referral or transfer was made, what your clinical thought process was, and the communication with the receiving provider. We also have a YouTube training video in the resource section in TrueRCM that walks you step by step through how to document a full referral note to keep things clear, clean, and defensible. This is the core of why it all matters. As nurse practitioners in long-term care and primary care settings, our work does not exist in a vacuum. Everything we do has to align with federal and state guidelines, survey readiness, risk reduction, and interdisciplinary teamwork. Our ultimate goal is to follow CMS guidelines and maintain compliance, pass ACA, CMS, Joint Commission, and RAC audits, not by scrambling at the last minute, but because our documentation and care already meet the standard. Defeat and prevent litigation by providing and documenting evidence-based defensible care. Collaborate effectively with the IDT because care coordination and communication are at the heart of good outcomes. This isn't about making your job harder. It's about practicing smarter, protecting your license, and improving patient care. If your notes, orders, and decision-making align with CMS and evidence-based practice, you'll walk into any survey or chart review confident. Here we highlight why antibiotic stewardship is critical in long-term care. We know antibiotics save lives when used correctly, but when they're overused or misused, they create more harm than good, especially in frail elderly adults. We're talking about C. diff, drug interactions, and survey findings. As nurse practitioners, our job isn't just to order, it's to decide if antibiotics are needed at all. That's why we rely on McGear's criteria to make sure symptoms actually meet infection thresholds, interact care pathways to guide when to treat, monitor, or transfer, evidence-based protocols like EMRI, antibiotics, Sanford Guide, and Hippocrates to match the right drug, the right dose, and the right duration. We also need to document clearly the indication, the supporting clinical criteria, the planned course of therapy, monitoring parameters and reassessment. Antibiotic stewardship is not about withholding care. It's about delivering the right care to the right patient at the right time and protecting our residents, our facilities, and our license. This slide is critical because if you only take away one prescribing safety tool, it should be McGear's criteria. McGear's criteria gives us standardized clinical triggers for diagnosing infections in long-term care residents. Why this matters. Long-term care residents often present atypically, no fever, no clear symptoms. Overprescribing based on vague findings like cloudy urine or a little cough is one of the biggest sources of antibiotic misuse. McGear's criteria provides objective, evidence-based thresholds for when an infection is actually likely. How do we use it? Well, you use it before prescribing antibiotics. Does the patient meet the criteria for a suspected infection? Use it as part of your documentation. Clearly note which McGear's criteria are met. Use it in combination with interact pathways to decide whether to treat in place or whether to escalate. If criteria aren't met, monitor. Don't reflexively treat. This protects your patient, reduces resistance, and backs up your clinical decision legally and regulatory-wise. If you're ever questioned during a chart review or audit, McGear can be your clinical shield. So here's just a blank sample, and you'll see it attached in the email for the McGear's criteria for infection surveillance. And it's just a 4-page continuous document on multiple infections. So the first one we're talking about is maybe a UTI without an indwelling catheter, and there's one right below it with an indwelling catheter. So in order to use the diagnosis of a urinary tract infection and to treat, you must have both 1 and 2 present. So the first one are your symptoms right here. So you're going to have at least one of the following signs or symptoms. And here they are. So you're going to have at least one of those, and then if no fever or leukocytosis, then you're going to have 2 of the following: suprapubic pain, gross hematuria. And remember, gross hematuria, if you're on Eliquis, Pradaxa, Coumadin, Xarelto, please look into that. Don't just assume it's a UTI. New or increased urgency, incontinence, or frequency. And then that's your first. Your second needs to be your result. So if you're doing a urinalysis, you have to have 50,000 or more bacteria and not more than 2 organisms. If you have 3 or more organisms, you have a contaminated sample and you have to get another one. The second one says that you only need 20,000 of any organisms if collected by an in and out catheter. That means if you straight cath a patient and they have 20,000 plus bacteria, then, well, it would be 4 plus bacteria, but if 20,000 of that organism, then that would meet this criteria. So remember, you have to fulfill both 1 and 2. Now, if you go down and scroll through the McGear's criteria, you can see that it addresses UTI without and with a urinary tract infection. They've got a common cold, influenza, pneumonia, bronchitis, cellulitis. I love some of these things that say you have to have at least one of these issues to call it cellulitis. So you have to have pus at the wound, skin, or soft tissue site, or at least four of these. So when you see this list, not only can you list the positives, but you can turn around and list the negatives because you have the list right here. So for example, you can say that the patient has heat, redness, swelling, and pain, however, denies any serous drainage, fever, leukocytosis, or exhibits no serous drainage, fever, leukocytosis, change in mental status change, or functional decline. So at least 4 of these. So they give you the words on how to document what the patient does have for positive symptoms, but also what the negative symptoms are. There's the scabies, oral candidiasis, fungal skin infection, conjunctivitis, gastroenteritis, the norovirus, and then C. diff. So this is an amazing worksheet that you can use. It's 4 pages. It's easy enough for you to have on your desktop and utilize. This is where we go from does this meet infection criteria to what is the next best step for care. So once McGear's criteria confirms whether the infection is likely, Interact Care Pathways give us a structured clinical decision making. And really, the nurses should be using the Interact tool, but we should know what it is and we should be able to utilize it as well. Most of what they're going to have on the pathways are going to be things that you're going to either ask the nurses or assess the patient if you're in the facility. So these are great pathways on what steps to take to rule out an infection or a problem. Why does this matter in long-term care? Well, because our residents often have complex comorbidities. So not every positive lab or subtle change means hospital transfer or antibiotics. And Interact gives us evidence-based pathways to support treating in place when appropriate. It helps standardize care across providers. So whether it's me or another nurse practitioner, the decision-making framework stays the same. It also helps us avoid unnecessary transfers, which reduce patient risk and facility citations. So how to use it? First, you're going to assess McGear's criteria to confirm the clinical threshold. And then you're going to use the relevant Interact pathway, whether it's UTI, respiratory, mental status change, etc. So here is a care pathway that defines a urinary tract infection. So most of the stuff that's on here in blue would be what the nurses would present to us. But because we're not rounding for 1 hour a day and we're there 4 to 6 hours, these may be patients that we're actually assessing ourselves. So first thing, are there symptoms of a UTI? So these would be some symptoms that a nurse may call you on, or the patient may express to you, or while you're doing rounds, the nurse may say, this patient is exhibiting this. So these are some of the signs. The next step goes to the nurses obtaining vital signs. So if you're at home, they can do that. If you're in the building and you don't want to stop and wait for vitals, just go ahead and check them yourself. But after you've got your vital signs, then the next question is, are any vital sign criteria met? Which they've listed quite a few. If you've got an elevated temp, an elevated heart rate, or a low heart rate, your respiratory rate, and they give you parameters on what you should be alerted to. So if yes to any abnormal vitals, they're supposed to notify the nurse practitioner, the doctor, or the PA. That would be us. If no, then they're going to go to the next section. So let's say you've got a patient, you've looked at their vital signs, they're already documented for the morning, but they're complaining of these issues right here. Next, we are going to evaluate for abdominal distension, new or worsened incontinence, suprapubic tenderness. Again, these are key things that you document. Document the positives and then document the negatives. No pain or tenderness, no gross blood in urine, appetite within normal limits. So positives and negatives. If not, if they are having symptoms, they're going to notify you. Or if you're evaluating, then you go to the next step. So the consideration would be, consider obtaining a urinalysis, getting a culture and sensitivity. In the state of Florida, we use PCRs. I would be investigating in Pennsylvania if you use PCRs. The urine PCR, if you get it done in the morning, the results should be back later on that afternoon. So you should have results in less than 8 hours. Do you need to get a CBC? Do you need blood work? Do you want a white blood cell count? If they had a catheter in the hospital and they've been here for 1 day, it may be advantageous for you to have them urinate and get a post-void residual to see if after hospitalization and removal of the catheter, if they have any residual. And then if you do end up putting them on antibiotics and they're on Coumadin, make sure you're checking that INR every 3 to 4 days. Were tests ordered? What are the results? Critical values in blood? If yes, notify the doctor or the nurse practitioner. So they will be notifying you, whether it's by phone or whether you're in the building, they will be finding you. Watch out for your labs. You should be checking your labs daily. Do you have an elevated white blood cell count? Do you have a post-void residual of over 350? They need a catheter at this point, and then you need to do bladder training for a day and then try to remove it again. Urine indicates infection. If yes, notify the nurse practitioner. That's us. So you can see how this could be for the nurses to utilize. And yet, while we're in the building 4 to 6 hours, this can totally be our documentation as well as what parameters we follow, so that there's never any question about us giving too much medication or starting antibiotics with patients that don't meet criteria. Then we're going to determine whether we're going to treat in-house or whether we need to transfer out. So yes, obviously monitoring vital signs, fluid intake, IV fluids, get a culture, consider antibiotics, discontinue antibiotics if culture negative. So if it's going to take you 3 to 4 days to get your culture and sensitivity, and they are having a lot of symptoms of a urinary tract infection, and you do start them on antibiotics, as soon as that culture comes back negative, it needs to be discontinued. And then updating the care plan as needed. Before you ever write an order or hit that e-prescribe button, you need to pause and think critically. Prescribing is not a reflex. It's a clinical decision that has a ripple effect on your patient, your facility, and your license. Here's what the pause should include. First, what's the actual problem? Are symptoms acute? Are they chronic? Are they unclear? Are we treating a real condition or a lab value? Does the patient meet criteria, especially for infections, pain meds, or controlled substances? What's their history and comorbidities? Could this medication worsen another condition, such as CHF, delirium, or renal impairment? What's already on their med list? Think interactions, duplications, and polypharmacy. What monitoring will be required? Think of labs, side effects, follow-up intervals. What is the de-prescribing plan, especially for antibiotics, opioids, psychotropics, or short-term agents? This quick clinical gut check is how we protect patients and ourselves. Remember, evidence-based practice, that's our focus. Your DEA license, your nursing license, and your facility can all be impacted by a single unsafe prescription. But more importantly, so can your patient's quality of life. This slide speaks to the reality of what many of us see every day. We often don't order what we should, not because we don't know better, but because of workflow, pressure, or old habits. So here are some common pitfalls I want us to reflect on as prescribers. Assuming that someone else has already ordered it. This happens all the time with labs or consults. In reality, the patient goes weeks without appropriate monitoring. So think about your primary physician in the facility and his mid-level. Let's say they're in there 3 to 5 times a week. Are you thinking that they're going to order that? Or are you thinking they're going to get mad that you're ordering that? Or are you thinking that it doesn't matter if you order it, they're just going to discontinue it anyway? By utilizing evidence-based practice, they're not going to discontinue it because what you've put in place is appropriate. Ordering based on old patterns, not evidence. We always do this, is not clinical justification. If it's not supported by evidence-based practice, it may not be appropriate anymore. Avoiding orders not to rock the boat. I see this a lot, and we have a lot of strong physicians, and their mid-levels are very strong as well. We don't not order because we don't want to rock the boat. We're not afraid of people with strong personalities. We work with them and around them. Resistance to change is difficult, but it's easy to default to minimal intervention. But that's not safe medicine. Lack of clear ownership when the doctor, the nurse practitioner, and the IDT all think someone else is responsible, and then the patient falls through the cracks. Or fear of over-ordering or getting dinged for the cost. Remember, appropriate monitoring is not over-ordering. It's good clinical care and defensible in audits. Our job is to stand confidently in evidence-based practice. If baseline labs are needed, if monitoring is required, if consult is warranted, order it. Document why. That's what protects the patient and your license. I want to thank you for spending your time with me. I know that it's not easy to always jump on a Zoom call all together. Mandatory, you got to be there at a certain time. I try to do these YouTube videos so you can watch them at your convenience. This one just is our yearly one, so it happens to be quite long. I think there's a lot of good information, a lot of good apps that you can download, a lot of stuff that I'm going to attach to this email for you. But if you have any questions, if you want to reach out, if you need some collaboration, just know that I'm here for you. I'm here to support you, help you with whatever you need to have. And I thank you again and have an amazing day.